puberty in teenage boys by Dr. Bothinah Alsharafi, consultant endocrinology.
Can you hear me? Okay, good. Today we'll be talking about managing boys with delayed puberty. And I see a lot of patients with this problem, and I'm sure you also see them. And it's usually the boys who make their parents bring them to the clinic because they see some of their friends, they've all grown up and started having mustaches and beards and so on. And they feel that they're like little kids next to them. So it's a very common problem, and it's usually the boy that wants to come and get treatment. So when do we consider puberty to be delayed? If there is incomplete development of secondary sexual characteristics, about 2 to 3 standard deviations above the mean age of onset of puberty, which is 13 to 14 years. Puberty is considered to be stalled if the patient does not have completion of the puberty within 4 years of the onset of puberty. So what are the causes? It's very common. It occurs about 5% in healthy individuals. Secondary hypogonadotrophic hypogonadism is more common than primary. The most common cause is constitutional delay. So everything is normal, but there's just a delay, a couple of years in the onset of puberty. It occurs about 63% of the patients. Functional hypogonadotrophic hypogonadism occurs in 19%. That means the patient has some sort of chronic disease which caused a delay in puberty. They have, for example, celiac disease, hypothyroidism. So it's not actually a problem in the gonads themselves, but there's a chronic disease causing a delay in puberty. Other causes, which are rare, as isolated hypogonadotrophic hypogonadism, including Kallmann syndrome, or central nervous system tumor. This occurs in about 12%. Primary hypogonadism occurs in 13%, and some other rare causes. Primary hypogonadism, we say, occurs about 13%. What helps us diagnose this is there's a high LH and FSH with a low testosterone level. They have small gonadal size, low gonadal steroids. Common causes are Klinefelter syndrome, gonadal injury from chemotherapy, radiotherapy, infectious diseases like mumps, cryptorchis, or other disorders of testosterone biosynthesis. Secondary hypogonadism is the most common. We have low gonadal steroid and the normal LH and FSH, or low LH and FSH. The most common, we said, is constitutional delay of growth and puberty. And these might have a family history of puberty. Sometimes the father will say, I was also late in developing puberty. And sometimes they don't have a family history. Isolated gonadotropin releasing hormone deficiency. There are many different genetic mutations which can be associated with it. They might have anosmia, as in Kallmann syndrome, or other congenital diseases. And the hypogonadism is usually permanent, so they're not going to improve with time. Functional hypogonadotrophic hypogonadism is associated with other medical illnesses like poor nutrition, chronic illness, celiac disease, hypothyroidism, or if we have hypothalamic or pituitary injury like surgery, craniopharyngiomas, malformations, hemochromatosis. All of these can lead to delayed puberty. What do we do? How do we evaluate these children? Usually we do a testosterone, LH, FSH. It can differentiate primary from secondary. But if we have secondary, sometimes it can be difficult to differentiate. Is this just a constitutional delay, or is this gonadotropin releasing hormone deficiency? You might have to follow them up for a time until you find out that this is actually hypogonadism and not just a constitutional delay. What are important facts in the history that we should take? Is the pubertal development totally absent, or did it start and then stop? The patient have nutritional habits or medical illness or engage in intense exercise that delayed the onset of puberty? Does the patient have any other congenital abnormalities or neurological symptoms? Is there a family history of delayed puberty? Does the patient have a normal sense of smell? All of these might help guide us. Is this a secondary, is this just a constitutional delay, or is there actually a hypogonadotrophic hypogonadism? On physical examination, we want to check the height, the weight, the arm span, secondary sexual characters. Serial measurements of height and testicular size over 1 to 2 years will help us see if there is actually a progression in puberty. If there's an increase in the arm span more than the height, then this patient might be having Klinefelter syndrome. And we should stage the secondary sexual characteristics by Tanner staging. And if you have a testicular volume of 4 milliliters or more, then this helps us. This is encouraging that the boy might actually start going into puberty. A bone age is important, especially if some of these kids, most of them come because they're short, more than because of the delayed puberty. And if you see a very big difference in the bone age in relation to the actual age of the patient, this might help, make us think that there is actually a growth hormone deficiency also, not just delay in puberty. We check the CBC, ESR, creatinine to help us if there's any medical illness that might be causing a delay. Liver function test, tissue transglutaminase antibodies for celiac disease. Like we said before, LH, FSH, testosterone. We don't need to do a gonadotropin stimulation test because in the beginning, it doesn't really help us differentiate whether this is just a constitutional delay or do they actually have hypogonadotrophic hypogonadism. Prolactin levels may be needed in some cases, growth hormone, IGF-1, thyroid function tests. If the patient has neurological symptoms and also has a low LH, FSH, we might need to do an MRI of the brain with the concentration on the pituitary. Test of olfactory function if we suspect this patient might have Kallmann syndrome. Genetic testing might be needed, and also testing for iron overload. Of course, we don't do all of these tests for all of the patients. Usually we'll check an LH with the testosterone. We'll do a CBC, thyroid function test. If you're suspecting that there might be a high prolactin, we might do that. If there is evidence of a chronic disease, the patient complains of diarrhea, abdominal pain, is pale, anemic, and so on, this might make us check for celiac disease or other chronic illnesses. How do we treat this? Of course, if you have any medical condition, you have to treat it. If the patient is hypothyroidism, you have to treat. If the patient has celiac, you have to treat. And usually the patient will start growing without having any specific treatment for the delayed puberty. If you have a craniopharyngioma, the patient will need surgical resection. And if you have Klinefelter syndrome or so on, these patients will need to be started on testosterone therapy. If the patient has constitutional delay of growth, like we said, it's sometimes in the beginning it's difficult to differentiate whether this is actually isolated gonadotropin releasing hormone deficiency or a constitutional delay in growth and puberty. And the approach is similar for both. So there's no need to spend a lot of tests and so on. You can give a short course of testosterone, whether you have this or the other, it doesn't matter. Sometimes you can discuss with the parents and you tell them, okay, everything's okay, it's probably just a delay. He's probably start going into puberty soon. And some of them might be willing to wait and watch. But the majority, usually the boys, they want to start treatment right away. So we can give a short-term hormonal therapy with testosterone in boys. So how do we start? What age should we start? Some doctors start after the age of 14 years. Some start at the age of 13 years. And they found in a study on a lot of doctors that treated boys with delayed puberty, that the more the experience the doctor had, the more likely they were going to start at a younger age. So usually 13 is a good cutoff if you want to start testosterone therapy. what is the dose we should start testosterone? We don't want to give it a big dose so that we won't have rapid maturation of the epiphysis, and then the patient will be short after that. So we can give 50 milligrams of testosterone every 4 weeks for 3 to 6 months, and reevaluate, and if needed, we can continue for another 3 to 6 months. And usually with this dose, you see the boy, they start to grow, they're happy, the family is happy, and you get the result that you want. Because if you give a high dose right away, if you give the whole ampoule 250 milligrams or so on, this might lead to rapid closure of the epiphysis, and the boy will, after that, be short. Another review showed that they started at 50 milligrams, and if needed, they would increase at the increments of 25 milligrams, but not more than 100 milligrams monthly. And again, could be used for up to a year. In patients with hypogonadotrophic hypogonadism, initial treatment is the same. Induction of puberty with human chorionic gonadotrophins and FSH. This should be reserved only for patients who have documented hypogonadotrophic hypogonadism. For example, they've had pituitary surgery, they have a craniopharyngioma, they're panhypopituitaris, and we know that they will not go into normal puberty in the future. Those are the ones that we can use the human chorionic gonadotrophin. Otherwise, there's no indication initially. You can just start testosterone, it's cheaper, it's easy to use once a month, and you get the same results that you want. So in summary, constitutional delay of growth and puberty and gonadotrophic hypogonadism may be impossible to differentiate initially. Treatment with a low dose of testosterone monthly for 3 to 6 months and can be repeated up to a year. Human chorionic gonadotrophin and recombinant FSH should be reserved for patients with confirmed hypogonadotrophic hypogonadism and may improve fertility when compared to treating with testosterone alone. So, if you have any questions, I'll be here for a few more minutes.
Thank you, Dr. Bothinah. Dr. Bothinah wants to leave. Any question or comments?
Thank you, Dr. Bothinah. Actually, this is a message for me and for all of us. We are a surgeon, we are not endocrinologists. So we have endocrinologists. For me, I never given a hormone for baby, whatever the age, unless testosterone cream at the puberty or dihydrotestosterone in the young age. In my presentation, you'll show complication of hormone therapy. So for us, it's the message, I think, from Dr. Bothinah, for us. We are a surgeon, we are not endocrinologists. So to give a hormone, whatever, pregnil or testosterone for patient, will enter in complication, bad complication. So what will be for us if we send the patient for endocrinologist for our college? We have a good relation. I have a good relation with Dr. Bothinah in intersex patient, especially. We have now with her more than 100 cases over 15 years. So it is a message for us. We are a surgeon, we are not endocrinologists.
Thank you, Dr. Bothinah, for this good presentation. I'm asking about the microphallus for this teenager. What is your approach for this case?
Is testosterone normal?
No, he is in the 12, 13 years or in the puberty.
Yeah, that would probably be the same treatment. Usually they go by testicular size. Okay, because once they go into puberty, usually everything will improve.
No, if
the family is very concerned, maybe a tiny dose of testosterone. Sometimes we see in obese patients, they have the penis is inside the abdomen.
Yeah,
and just giving them a tiny dose of testosterone, everybody's happy. The penis comes out and everybody, the boy is happy, the family are happy. And it's just because of the obesity and the penis is inside. And if it's very small, also you can give a small dose of testosterone. A small dose, don't give a big dose. 25, 50 milligrams would be enough.
Dr. Lutfi.
Thank you, Doctor, for this subject. We have a question regarding undescending. There is controversy or debate between us as a urologist as a using of hormonal therapy in treatment of undescending testis. Sometimes they prescribe, if the child is 2 years, 3 years, 10 years, they still prescribe hormonal, trying to make the testis to go down. In my practice in Jordan, I didn't use hormonal therapy at all. Whatever the patient. Sometimes some doctors, they advise to do or to prescribe testosterone, or human gonadotropins once the age is less than 6 months. And it is a little bit down to the neck of the scrotum. And if it is bilateral, but once he passed 6 months and once he 1 year and above, they say no role for this hormonal therapy. What's your opinion regarding this point?
I really don't have any experience. I can't advise you.
Anyone of us, anyone of our colleague has some experience? الدكتور محمد حيوضح الفكرة هذه في دكتور إسماعيل.
Yes, thank you very much. Yes, by the untended testis, bilaterally untended testis, there is you can do use BCG, beta, until 6 years of age. If it's bilateral, it is recommended in some books. You can try before surgery. Bilateral, bilateral untended testis. Okay. We have, in some cases, good result, especially if the testes are more down in the inguinal canal. The successful rate is more. You can some.
Dr. Mansour.
شكرا دكتورة بثينة. Regarding the undescending test, we all know that the descent of the testes from the abdomen down to the scrotal sac is depend to anatomical and hormonal factor. So if the undescending testis is bilateral, mostly the problem is hormonal, and this patient can be get benefit from hormonal treatment by hormonic gonadotropin. And from our experience, we saw good result for the patient treated by this way.
Dr. Bothinah.